Welcome to the afternoon sessions at a conference. Those are the fun times, right? When everybody's had a full day already. It's good to see a lot of friendly faces and colleagues and a lot of new faces this year. My name is Josh Butler, and I am the president of Butler Benefits and Consulting and also of a health plan called High Plains Health Plan. I'm from just up the road a few hours in Amarillo, Texas. And I first want to start out and say, because they're recording these sessions, thank you so much to FMMA for having me come this year and to share a little bit of our experience and what we're doing. And we're going to be talking today about breaking cycles and everything, but this is just a little bit about me. I mentioned High Plains Health Plan, which we're going to talk a little bit about later. For the work that we do at our firm and with High Plains Health Plan in 2022, we launched High Plains Health Plan, and I was also recognized as Broker of the Year through Benefits Pro. I always tell people that's an individual award, but it is absolutely 100% a testament of the work that our organization does. I've got a phenomenal team of people, and I'm also a pretty lousy FMA chapter leader in Amarillo too. So I had to, me and Kelly were joking about that earlier. But anyways, it's good to be here, and we're going to jump in. The title of the talk today is Breaking the Cycle and what employers can do to take back control of their health plans, because so many employers just feel like there's nothing that can be done. So really quickly, show of hands. Are you an employer? Raise your hand. Great. And clinicians? Excellent. This should be good. Should be fun. Breaking the cycle. So I want to start just by kind of explaining the cycle. And I know that this is kind of painting with a broad brush and it's a generalization, but over 20 years in this industry, I can tell you it's a pretty accurate statement that the vicious cycle, it's a vicious cycle that employers are subject to year over year. And it usually starts out where an employer renews their health insurance out of frustration. I have had so many people tell me over the years, I'd rather wrestle a tiger in a phone booth than deal with health insurance. I hate health insurance. I hate this part of my business, and I wish I didn't have to deal with it. And they're very frustrated. But oftentimes they'll get through that renewal cycle. They'll renew out of frustration. And then what happens? They forget about it for months and months and months. They just forget about their health plans. There's no proactive risk management. And then guess what happens? In about 90 days before, they renew again, their broker comes to them and says, well, I got news for you again. You're getting another 9%. You're getting another 12%. You're getting another 20%, whatever it is. And what have most employers done in the status quo environment over that time period? How do you get a 20% renewal down to a 10% renewal? Cost shift is the number one way that most employers are doing it. They're raising deductibles, they're squeezing their networks, they're watering down their benefits, and this leads to more and more and more exacerbated frustration year over year. Then, this is what we call reacting. They're reacting to a 20% renewal. When you get a 20% renewal, it's too late, right? It's too late to really do anything about it. The claims have been experienced, the money's been spent. There you go. There's nothing you can really do to control that renewal. Now you can go and you can beg and you can twist arms and you can threaten or you can raise your deductibles sky high, but that strategy right there has a shelf life. What do you do when you're already offering an $8,000 deductible and you get another 20% increase the next year? You have no more runway. You have nowhere to go to get premium relief. And by the way, raising deductibles does not lower healthcare costs, does it, David? It shifts it. It shifts it to the most vulnerable people in the organization, the employees, right? So it's not lowering cost. It's not solving a problem. It's putting a Band-Aid on a bullet hole, right? And then the broker comes back with about the same 3 or 4 options. Here's your Blue, here's your Cigna, here's your UHC. They might get a little creative with an ICHRA or a level funded plan, okay? And then that's your options. And then what happens? The cycle starts over and they renew again out of frustration. They don't know what they don't know. And we're going to talk about that a little bit later. I'm going to use a case study. And people ask me all the time, Josh, why do you viciously attack the status quo? And the reason that I do and attack this cycle is because everywhere the status quo goes and everywhere it's allowed to persist, it wreaks havoc and it hurts people. It's harming people. There's a reason that Warren Buffett says healthcare is the tapeworm of the U.S. economy. And there's a reason for that. It is sucking the life out of our public sector entities, our school districts, our municipalities, our county governments, local private businesses. It is just sucking money and resources away from things that we could be spending our money on. Now, breaking cycles, I'm going to tell you something right now, is disruptive. This is a disruptive conference, right? And we kind of wear that as a badge of honor that we're disruptors, right? And I'm going to come back to that here in a little bit. I'm going to finish with that point about disruption. But first, we were just recently consulting with a large municipality in Texas that just in 2018 and 2019, that's just 6 years ago. Just 6 years ago, they were spending $22.8 million on their medical plan. They budgeted $36 million this year. That is a massive increase. And went back, I just did the slides back to 2018, but we actually did an analysis for this city all the way back to 2010. So this city has trended at 9% year over year for the last decade, 10 years. Some years it'll be 4%, some years it'll be 14%, but year over year, they're trending at 9. When you trend at 9, you double in 7, just under 7. Their rates will double again in the next 7 years. You continue to trend at 9. This is status quo. This is what the status quo, they've done the same thing with the same ASO carrier, the same PBM, the same stop loss, the same brokers for more than 10 years. And this is not performance. This is a poorly managed health plan. Well-managed health plans trend at 3.5% to 5% per year. Poorly managed plans trend at 8 to 10. So they're right there, right along with a lot of companies in this country that are trending at 8, 9, 10, 12%. It's unsustainable. So when we project that out, part of our analysis that we did for this city, even if they were to immediately address trend right now, and do the things that all of you guys are doing in the FMMA world and the innovative cost containment and the independent PBMs and the great strategies that we come to these conferences and get to talk about and hear about. If they could immediately reduce their trend to 4% per year and trend at 4% over the next decade, if they continue to trend at 9, by 2035, they're going to be at $85 million. And this is a municipality. This is taxpayer money, okay? So we're bordering on dereliction, right? It's like, you got to do something about this. You got to get control of it. Whereas if they trend at 4, they're going to be, that's about 53 million right there. So that's a $30 million difference in 1 year. 1 year, it's a $30 million difference in 2035. Now, how much can they save if they were to immediately reduce trend and trend at 4 over the next 10 years versus 9, like they have done the previous 10 years. So we project that out as well. There's the number right there. In 10 years, this is not a major, huge city in Texas. They're pretty large with a $36 million spend in their medical plan. They're pretty big. They're right at like 5,200, I think. 5,200 members is what they are. About a little over 2,000 employees. It's $146 million. That's the difference between a 4% trend and a 9% trend on a $30 million plan. It's $146 million in a decade. What do you think that city could do with $146 million over the next 10 years besides spend it on healthcare? You can hire a lot of cops, firemen. You can pay your people a whole lot more. You can fix potholes in the streets. You can fix aging infrastructure in your water treatment plants. That's a lot of money. But this is why we attack the status quo so bad. This is the result of people that are just setting it and forgetting it year over year over year. And how do people break these cycles? That's what we're talking about today. But I just kind of wanted to show you about what the status quo, this vicious cycle that we're all trying to break, what it looks like in reality. And these have real impacts on communities and private companies. It's the product of the status quo. Employers are stuck, but why are they stuck? So again, I've been doing this for a little while, and we talk to a lot of employers all over the United States. And I can tell you that employers are stuck in their ways for some reasons are kind of legitimate. I understand where they're coming from, and it's fear-based. And what we are trying to prove in this community and communities across the country is alleviate these fears and give people hope again that they do have alternatives. But here's some of the main reasons, and they're all fear-driven. Disruption to employees. What if my people get confused, or what if they get upset? They've been with Blue Cross Blue Shield for the last 15 years. You guys know in your own organizations, and if you're an employer, I know this is one of your concerns. Is this going to be too disruptive for my company? The last thing that the CFO wants, or the CEO wants, is, my insurance sucks. What did you do to my insurance, right? The second one, losing broker or vendor trust. If I've heard it once, I've heard it a million times. Oh, I've been with my broker for 20 years. We go to Sunday school together. I get it. I understand relationships. We like to build relationships too. But I'm going to tell you about another relationship they better start paying attention to as employers. And it's the fiduciary relationship that you got with your employees, because they're starting to be groomed by law firms in this country to sue you as employers for failure of fiduciary responsibility. I think could be argued that a city that's trended at 9% doesn't get 100% of their rebates, doesn't have a carrier that will allow them to pursue cost containment strategies. That's a failure of fiduciary responsibility. When there are solutions, and we're going to talk about that here in a little bit, or in just a second. Complexity of change. This sounds like a ton of work. Now I'm going to talk, is there any HR people here? Human resources. Not to pick on HR, but when you hear about all these strategies, and change often equals what? More work for me. This sounds like it's going to be a whole lot more work. And I get it. People are already working hard. HR managers are already extremely busy. Benefits is not the only thing that they take care of and manage. So this is another one. This is a legitimate concern. You know, am I going to have to hire more people if I change into a plan like your High Plains Health Plan? I get asked that quite a bit. How many people are going to be needed to support these types of plans? Being blamed for backfires. This is one of the biggest ones that we get. And this one has some legitimacy to it, is that nobody gets fired for hiring Blue Cross Blue Shield. Everybody's got job security. We chose the biggest broker in the country. We chose the biggest carrier in the country. Your job's protected. Well, I understand that if you fire those people and do something different, what if it doesn't turn out well? It could be your job. And that is a legitimate concern. And that's why it's so important. Case studies are so important. And vetting these vendors are so important. And getting to know people at these types of conferences are so important. And then lack of transparency. Employers simply don't know what they don't know. And at my firm, with our salespeople that we send out and that market our plans and things of that nature, I use a crude analogy. I'm a storyteller. I love to tell stories, and oftentimes I use analogies. If you don't like analogies, sorry, I'm going to use one. But it's a crude analogy, but it's about this point right here, that employers don't know what they don't know. I hope to God that I'm never judged by anybody based on something I didn't know about, right? There's a reason that there's a saying called ignorance is bliss. But here's the analogy. What do you do when you find out your brother beats his wife? Before, you're not responsible for that. But when you find out, it creates a dilemma, right? It creates an instant dilemma. I love my brother. I don't want to hurt my brother. I don't want to see my brother get in trouble, but I also love my sister-in-law, and I love them little nieces and nephews. And I don't want my brother harming my family. So hopefully, we would all make the same decision in that scenario, right? You have a choice to make. Do you intervene? Do you do something? Do you step in? Do you confront? Do you turn him into the cops? Do you step in to protect your sister-in-law and your nieces and nephews? Or do you just ignore it? It's none of my business. I'm just going to turn a blind eye. It's not my family. It's not my business. It creates a dilemma. But before I knew that my brother was beating his wife, I'm not responsible for that. But do you become somewhat responsible after you learn things? Yes, you do. And so this is what we teach our salespeople. Get out in the market and create a dilemma. Because now, employers, you're not going to be able to use ignorance as an excuse forever. I didn't know that these solutions existed. I didn't know High Plains Health Plan was an option. I didn't know that, Kelly was doing there was a broker in my community doing this kind of work. Ignorance is not always going to be an excuse. So keep preaching, all of us. You got to keep out there and spreading the gospel, right? These are the main reasons why employers are staying stuck in the status quo. It's fear-based. They're afraid that if they make changes, that it'll be a mistake and it could cost them their jobs, and all of these things are legitimate reasons. What's breaking the cycle look like? I'm going to give you some specific points that you can do. The first thing is companies need to conduct comprehensive audits. And even the clinicians, you may think, well, I'm not an employer, or I'm not a major employer, and I don't even have health insurance in my company. You can help brokers, you can help health plans, you can help TPAs. It takes a big audience and a big community to achieve results. But get a comprehensive audit done, okay? And I mean audit everything you can about the health plan. I know what everybody's gonna say. You can't always get data. What if they're fully insured? I get that, but you gotta find people that know how to get information, because even in the fully insured environment, you can get specific types of data. The Consolidated Appropriations Act gives you title to it, legal title to it. It's your data, they can't withhold it. I have had my team tell me, because I've got account managers that have been account managers in this industry for 30 years. I'll tell them to get a report from a fully insured carrier. Well, they won't give us that. Ask for the report. They are giving it to us, because then we have to sometimes cite the provisions of the Consolidated Appropriations Act and say, well, the next letter might be from an attorney, or you could just give us what's rightfully ours, and we get the information. Start conducting comprehensive audits. Explore alternative options. Again, we're running out of excuses to say, well, there's no alternative options out there. I'm only got 3 options to choose from. No. There's people all over this country that are building very innovative solutions and very savvy solutions, and it's up to us to explore those options. The next is abandon the oligopoly. I recently read a book about, it's called The Death of Capitalism, and it's all about, monopolies and oligopolies in our country. And if look in our industry, look in the healthcare industry, it's one of the worst, okay? The tech industry is pretty bad, like Google search engine is like, that's basically a monopoly, right? But look in healthcare. In the PBM space, 90% of the market is controlled by 3 PBMs. In the fully insured world, how many carriers do you have in your market? 2, 3 that are legitimate? These are oligopolies. Vertical integration is wreaking havoc in healthcare, okay? And if you're the clinicians in the room, you guys see this. It's an epidemic where the big get bigger by eating the smaller and just acquiring you, vertical integration, and then prices go up. The same thing's happening in the PBM world, the TPA world, and we have to have an alternative to that, right? Collaborate with the clinical community. This has been the biggest learning experience of my career. When we launched High Plains Health Plan, we don't just have a plan, we also have a network. I've got about 3,700 direct contracts around the country, and we're building a network. I hate the term network, because I'm not going to be a PPO network. We don't monetize our contracts. We don't charge a PEPM. We don't take a percentage of savings. We don't take a percentage of charges. Every dollar that clinicians give us in discounts, we turn right back around and we give it to their patients through the form of a $0 deductible and $0 copays. So when we go talk to employers about breaking their cycles and looking at alternatives, our alternative, I'm proud of it, and I'm proud to say, we take discounts and savings that we generate in healthcare, and we're giving it back to the people that need it the most. And they say, this is impossible. How can you be so much cheaper and save us so much money, and you still offer a $0 deductible and a $0 copay? It's easy. Go talk to Keith Smith about the difference in the total knee in an HOPD, a hospital-owned outpatient surgery center, versus a true ASC. That's a $50,000 delta on one surgery. Well, if I save a plan sponsor 50 grand on a surgery, can we afford to eliminate a $5,000 deductible and still net save $45,000 for the plan? It's not rocket science. You have to get to the unit cost of healthcare. And for the point solution people in the room, if you're not getting to the unit cost of care, not shifting like a high deductible strategy does, if you're not reducing the unit cost of care, what are we doing? That's what's driving premium rates. If we get control of claims, like this city, if they would get control of their claims, they could eliminate that 9% trend and save $146 million in a decade. It's possible. Advocate for market and policy reform. Anybody see the news that came out of Arkansas this week? What the Arkansas House of Representatives passed? So it's passed the House. It's moving into the Senate in the state of Arkansas. So I don't know if it'll pass. I don't know about all politics in Arkansas. But I think other states do what? Oh, well, here's what the bill says. If you're a PBM and you own a pharmacy, you can own pharmacies. But in the state of Arkansas, you got to get permits to operate pharmacies in the state, right? If you're a PBM that owns pharmacies, you can own pharmacies, but you can't do both. You can't conduct business in this state as both a PBM and a pharmacy. Pick. You want to be a pharmacy CVS? Be a pharmacy. You want to be a PBM CVS? Be a PBM, but you can't be both. That's a good thing, right? What do you think they'll do? Just somebody make a prediction. You think they'll keep the PBM and they'd shut their pharmacies and disrupt all those patients? I agree with you. Do what? Sell to PE, sell to private equity. They'll do something. They're fighting it awful hard, but it's something y'all should watch that one really close, because if that precedent gets set, but we all know that's a conflict of interest, right? When you get to set the terms and you get to set the prices of your competitors as a PBM, you get to set the prices, what you pay other pharmacies that are your competitors. I mean, what other industry allows this, right? It's an interesting bill. Let's keep an eye on it. So let's talk about getting some results. What does it actually start to look like when you break these cycles and you break the status quo? So this is what it's possible. These are a few stats, and I'm going to just go through here. We launched High Plains Health Plan. We're approaching 5,000 covered lives, so we're not big. We're the only consulting firm so far that has marketed our plan. So we built very slow to try to get wrinkles ironed out of our plan and make sure it's doing well. We ran a pilot for about 12 months before we officially launched High Plains Health Plan, but I'm still going on 2022. Two benchmarks really quick. Since the 2022, across our block of business, we're running at about $7,000 per employee per year on medical. That's medical claims per employee per year. What's the national average for a self-funded plan? 15 grand. It's a little under 15. So we're about 50% better than the national average. Next benchmark, how much do we spend on pharmacy claims, and this is net of all rebates, per member per month? Anybody know the national average here? 102. We're at 72. Year-over-year trend is at 3.9%. So over the last 3 years, our groups have trended at 3.9. And then here's what we're really proud of. In 2024 alone, just last year, we had over 2,200 physician visits with a $0 copay. That puts money back in people's pockets. In the time when inflation's a real deal, and eggs and bread and gas and everything else, and housing and college tuition, you're getting it everywhere. People are feeling the pinch everywhere. So any relief that we can give them is really, really felt. We dispensed over 2,700 generic medications at a $0 copay. All generics are covered under our plan at a $0 copay. It's not where the plan sponsor's money goes. It's where 90% of your volume is and about 12% of your spend on pharmacy. And now we got to get a hold of specialty drugs. You can see here that our 4 biggest medications by cost across our 5,000 life population was Skyrizi, Ozempic, Mounjaro, and Humira, which now we've removed Humira from our formularies with our PBM because there's adequate biosimilars in the market and things of that nature. So, but these are the savings that we're generating on these drugs. We do deployed strategies like carve-outs, MAP-PAP programs, international sourcing. I'm a fan of do it all, whatever is effective, right? Because that's what our employers are asking us for. Show me how to save that kind of money. So when people ask us, can you help me save money in healthcare? Unequivocally, yes. I don't have to look at an ounce of your data. I don't have to answer any other questions except this. Yes, I can help you save money. But that's not the question. The question is, what are you willing to do as an employer to save the money? If you were willing to send all your employees to one DPC practice and only one, a really good one, and it would save $1 million, they probably wouldn't do it because that's just something that they wouldn't do. I'm not going to make my people go to one doctor, right? So it all comes down to what they're what the employers are willing to do. 275 deductibles waived on outpatient surgeries alone. Last year, we referred to ASCs like the Surgery Center of Oklahoma. As a matter of fact, we sent 8 cases down the highway because we didn't have it available in the Amarillo MSA. So they had the subspecialty here in Oklahoma City. So we send them up the road. They don't pay for anything. They don't pay a deductible. They don't have co-insurance, and they're happy to do it, right? And then when you break the status quo and you break this cycle and you start to adopt things, I'm going to tell you the last part of this case study was with another employer that we have in Tennessee. This man was, sorry if I butcher this, he was diagnosed with generalized myasthenia gravis, a pretty rare condition, but he was taking this medication here, Vyvgart Hytrulo. That medication had an annual price tag of $480,000, and it's infused in an infusion center. So it's not a pharmacy claim. What's this called? It's a J-code. It's a physician-administered drug, and it's a medical claim. So it doesn't show up in PBM and pharmacy data. It shows up in the medical data, $480,000. But we get to work. Stop Loss came to us and said, uh-oh, we're going to have to laser this guy. $500,000 laser, here it comes. So we got to work. I worked with some partners, including the patient, the patient's physician, 2 different infusion centers, the drug manufacturer, the PBM, the TPA, the CFO of the company, the HR team at the company. It was multiple stakeholders that had to be involved in this strategy. But we were successfully able to mitigate this risk 100%. We carved it out, we got manufacturer's assistance, and it sidestepped the $500,000 laser and reduced cost $480,000 for that plan. You cannot do this in the status quo. Cigna does not allow this. Blue Cross Blue Shield of Texas does not allow this, okay? We got a happy client and a happy patient, and he did end up having to go to a different infusion center where we have a direct contract. And this is what he texted me the first day he went for treatments. Josh, I'm doing my first infusion right now. He texted me from the chair. Things worked out very well, no problems whatsoever. Thanks so much for helping me with all of this. I'm very appreciative for all you've done. Miracles do happen, LOL. Now, why did he say that at the very end? Because he was involved in this process from the beginning. He got the front row seat when the status quo reared its ugly head and told him, you can't do that. Y'all can't do this. Yes, we can, and yes, we are. And we did it, and he's getting his treatment. So we're not talking about saving $500,000 by denying people coverage or benefits or the medications that they need. But you have to be able to use your creativity, number one, but you also have to start a new cycle and get with the right vendors, get with the right consultants that know how to do this work and execute this work. Because that's the last magic that the BUCAs have. What is it? They bundle everything up together and they make it really, really easy for employers to just implement their plans. That's their magic, okay? And that's where we're trying to get with what we're doing. So the last thing I'm going to tell you before we get to a couple of questions, if anybody has any. One of my favorite movies is The Dark Knight, you know, the Batman movie. And there's that scene, if you've seen that movie, where they're talking about Bane, he's the bad guy in the movie, you know, and he's trying to blow up the world or whatever he's doing. And that person asks Alfred, you know, the butler, and it's like, what drives men to this madness? And his answer was, some men just want to watch the world burn. Y'all remember that line? Some people just want to watch the world burn. What I want to leave you with today, and the last thing I want to share, is breaking the cycle is very disruptive, okay? But if you're just coming to burn it down, to burn the system down, that's not helping anybody either. We have to replace it with a new cycle. We have to replace it with new solutions. It's not enough to just burn it down. And so thank y'all so much. And if anybody has any questions. I should have written that down. I don't. I mean, you could probably Google it. Just Google Arkansas PBM bill, and it'll bring it up. So that's a great question. We're getting treated and priced as a captive without the formal formation of a captive, because we do put a lot of our stop loss with a small handful of MGUs and carriers. And so I get the benefit of economies of scale, but each group is individually underwritten with an understanding that we have a sizable block of premium with specific carriers. internally in our firm. Something what we do not do clinical steerage. I'm not a physician, I'm not a nurse, and we're looking at clinical navigation for the future, but for now, it's just concierge member navigation. They call our team. I've got a great team of, like I said from the top, I've got a great team of people. Nobody knows High Plains Health Plan better than we do. We've built it from the ground up. So members often will call us like, how do I find a tier 1 provider? We keep a directory on our website, just like any other health plan would. You can go online and search the directory and they know where they can go, where we have direct contracts. But as questions, a common question is sometimes somebody will go into a doctor's office and they'll look at that ID card and they'll say, we don't take this. Well, yes, you do. And I've even had to talk to people and talk to my doctor or the doctor's office. And we explain it to them and they're like, okay, because we have our own network, but we also utilize RAP networks, right? So we have national access points through RAP networks. You can lease Cigna, you can lease First Health, you can lease Aetna. So you can lease RAP networks. Not all of them will let you steer though. Not all of them will let you do the $0 plan designs. Some of them will though. We first went to Anthem and asked them if they would partner with us as a RAP, and they said no. They laughed, like Bill's laughing over here. Then we went to Cigna. Cigna was a yes in the beginning, but then they came back and said, no, we don't like your plan structure. We don't like this $0 preference stuff, steerage. We don't like that part about it. But when we pitched it to Aetna, Aetna was like, yeah, we love this. We want to partner with you on this. So we use Aetna a lot as a RAP. I do some RBP outside of our tier 1 network, because as that tier 1 network grows, I have less and less use for a RAP network over time. Oh, we do. We have PA. Yeah, we still put guardrails, because here's the deal. I'm not ready yet, but here's the cool part. Our UMDMCM provider says, here's our prior authorization list. You can't add to it. So you can't invent another reason to make a physician do a prior authorization, but you can take away from it. Now, I'm not a doctor, right? And so I'm a little scared of this a little bit. And when I talk to our legal counsel and people like that, I get a little iffy in this area. But I think that we are discussing with some of our tier 1 providers of completely removing the need for prior authorization. But y'all know, and especially you clinicians in the room, sometimes, it's just a fact. There are unnecessary care administered in this country. And it's a shame that we have to put physicians through these processes. But if all men were angels, no laws would be necessary, right? But the thing is like, so we still have clinical guardrails through prior authorization and pre-cert, but we do have control over if we want to make that more lax. I just can't make it more stringent, which was okay with us. The guy got his Vyvgart, but it saved $500,000. Our number one objective is to make healthcare more accessible and more affordable. We don't do that by just excluding benefit, excluding coverage for things. It's like if your doctor says you need Humira, okay, you need Humira. We're going to go source Humira for free, or we're going to get it for 60% less. Or maybe we have a conversation, or you have a conversation with your rheumatologist about, what about Euflyma? It's, a quarter of the cost, right? And they offer patient assistance. Well, is it appropriate? Go have that conversation. I'm not trying to play doctor. We just say, okay, if this is the drug or this is the surgery you need, my job is to help you find it for $0. And people will do that. They vote with their pocketbooks. It's a great question, because it's our number one challenge, because I don't have enough lives in Montana to warrant me to go to Montana and get a bunch of direct contracts, right? So it's kind of like one begets the other. So, it's not necessarily that. Healthcare is local. It's cliche to say that, but 87% of administered care is administered within a 20-mile radius of a person's home address. So it's cliche to say it, but it's very condensed. And so we can get direct contracts anywhere, but it's all about what we're proving is that the model is replicable. You could build a High Plains Health Plan in any market in the US. Nothing's stopping anybody from doing it. And so that to me is how you kind of get the things like this scaled, is because the model is proven, it's replicable, it can be done market to market, state to state. So, well, they've come in on me and told me that they're about to get this cane out and jerk me off stage. But we thank y'all so much. I'll stick around for a few minutes if anybody else has any questions.